Okay, welcome back everyone after our great implementation science session. So we now have our final formal session of the day, and this is our late breaker abstracts. So it's late in the day, and these are the abstracts that came in during late breaker time that were the top rated of all the abstracts, so chosen for oral presentation. So congratulations to all four of you. I will introduce them one by one. Each abstract presenter has 10 minutes, and we're going to start with Dr. Alan Gifford, who is a professor of medicine and public health at Boston University. He's a lead clinician for HIV and hepatitis care at the Bedford Veterans Affairs Medical Center. He's also director of the Center for Healthcare Organization and Implementation Research in Boston. And he's been a recipient of the Robert Wood Johnson Foundation Generalist Physician Faculty Scholar Award, very impressive, and VA Advanced Research Career Development Award. And his international HIV research experience includes work in Uganda, China, Vietnam, Russia, and South Africa. Over to you, Alan. Thank you.
Thank you very much. It's a pleasure to be here to present this qualitative, formative research on the implementation of antiretroviral treatment adherence strategies. And I represent the full authorship team, which is based in Cape Town, South Africa, and in Boston. And I'm also standing in for the first author on this abstract, Dr. Laura Sabin. Neither Dr. Sabin nor I nor anybody else on the team have any conflicts to report. However, we do want to acknowledge the support from the Boston University School of Public Health established Investigator Innovation Award program, which supported this project. And we want to offer our heartfelt thanks to all the individuals in Cape Town, patients, policymakers, and clinicians who participated in this research and who executed the research as well. So, in resource-limited settings, people living with HIV often have poor retention and adherence to antiretroviral therapy, as we all know. South Africa bears the world's greatest HIV burden. And in that setting, more than 20% of all those receiving care fall out of care as early as 12 months. Interventions that are tailored to local settings can improve antiretroviral adherence and retention. And we do have evidence-based strategies, but the translation of these evidence-based strategies into resource-constrained clinical settings has been slow. Why is this? Well, there are limited resources and knowledge of strategies that work, and we have weak, locally relevant evidence. In spite of this, in Cape Town, there have been great efforts made. Médecins Sans Frontières and the Western Cape government have established already a risk of treatment failure program. This risk of treatment failure program uses two different approaches, which are drawn from the literature and the evidence in patients with unsuppressed viremia. The general strategies are adherence support groups and adherence consultations with behavioral clinicians. Now, this risk of treatment failure program in place helps some, but frankly is far from optimal. In fact, viral resuppression only ranges from 30 to 70% in those referred for risk of treatment failure programs. Nevertheless, there's plenty of interest in Cape Town in implementing programs to improve adherence, and therefore improving this risk of treatment failure program is the focus of our implementation-based research. So we are conducting qualitative formative work at this time and presenting it here. The locally tailored, evidence-based, and personalized support program is an approach to taking evidence-based approaches, and the goal of our team is to develop, and it would be better to say actually locally tailor it and adapt it so that it could be used in ART patients who are at the highest risk of treatment failure. We've conducted, as I said, qualitative formative research among three groups: policymakers, patients, and providers in Cape Town with a three-stage strategy. The beginning phase was brief, and it is with the policymakers. We developed a list of effective, evidence-based, scalable strategies drawn from the literature and reviewed with leaders of the City of Cape Town's health office in early 2019. Certain strategies were removed from the list that we discussed if they were felt not to be feasible for broad implementation or if they were unsustainable without external research funding. The Cape Town officials further reduced the final list of strategies so that they were likely to be achievable and agreeable in their judgment in community-based clinics in Cape Town. That was our first step with the policymakers. We then went on to patients and providers, and the rest of this presentation will be discussing our results with patients and 3 different groups of providers. So as I've mentioned, this work was conducted in Cape Town, South Africa, during the months of July and August in 2019. This is the home to, South Africa is home to 7.7 million people living with HIV. Of these, 4.7 approximately are individuals that are taking ART. The project was comprised of in-depth interviews and focus group discussions. First, the in-depth interview part was with patients, and then the focus group discussions were conducted with providers. And these were done circling around 3 community-based clinics in the Cape Town area. The 2 patient groups, that is to say patients that had individual interviews, were from 2 pools. One was a pool of patients that had raised viral loads in spite of being treated with antiretrovirals. And then the second group was a group of patients who had simply discontinued care, who had fallen out of care. Then we also went on to conduct focus groups with 3 provider groups. The first group was a combination of physicians and nurses practicing in these 3 clinics. The second group was a group of community care workers drawn from the communities that were being served. And then the final group was a group of behavioral counselors. We focused our qualitative data collection on questions about ART adherence and retention, and about specific evidence-based intervention strategies. We really wanted to hone in on those strategies as well as learning about adherence. And I won't go through all of the questions that we used in our interview guides, but typical questions included: what challenges have you encountered in staying on HIV treatment? And which of these options, and I will show you the interventions in a minute, but which of these options do you think would be most helpful to you and why? So these cartoons show 2 things. One, they present to you the different types of intervention strategies that we discussed in these interviews and focus groups. And second, they also show how we presented them to the participants themselves. We found it to be useful to have these for focusing our discussions on. And first, there were 6 individual strategies that we began with when interviewing the patients. The strategies were, am I doing as well as other people? This was presenting data about individual patient adherence back to the patients using text messaging. The second was, let's see how you're doing taking your meds. This was a more counseling-oriented discussion of intervention performance with the individual. The third was general intervention, individual behavioral counseling. The fourth was a support group, getting support from a group around adherence. The fifth was a simple weekly check-in text, sending the patient a text to ask them broadly how they were doing on their medications. And then the sixth was what we'd call a treatment buddy, choosing a treatment friend to help the individual patient get through their treatment for HIV with HIV medications. Those were the 6 individual strategies we discussed. And then based, as it happens, in part on the results that we got in our individual interviews with patients. We chose later then to go on to combine some of these different strategies, putting together the text check-in strategy on a cell phone texting methodology with the different behavioral or educational approaches, the getting support from a group, the individual counseling, and the education around how the individual is taking their medications. So these were the 9 general approaches we discussed. This is a brief presentation that we don't need to get too deeply into, but is the demographics of the individuals that participated in our study. First, the participants were roughly equally divided between those with raised viral loads on therapy and those who had discontinued care, and were distributed according to male and female roughly equally. And then the focus group participants, as we mentioned, were roughly equally a focus group of doctors and nurses, a focus group of clinical community care workers, I should say, and then a focus group of counselors. So now on to the results. First, from the patient individual interviews. We found that the most frequent and popular strategy endorsed by the patients was group support from a group. It was expressed that confidence and motivation to openly share about their status and medication regimens was a positive result of this kind of strategy, often brought up. A typical quote, "It would help with talking and sharing things. By talking, sharing, and chatting about this thing and advising each other about taking medication." It was also mentioned frequently that check-in texts would be a useful modality. This was the second most commonly endorsed strategy. Texts to check in how you're doing would be convenient because the phone is always nearby and you use it nearly every day, and it is easy to respond. A typical quote was, "I think so because we always have our phones handy and you always use your phone." To a great extent, because of the primacy of these 2 strategies reported by the patients, we then, as I mentioned, decided to put these together in part when we then went on to conduct focus groups with the providers and ask them about that combined strategy. However, these weren't the only things that were popular among the patients. Patients also endorsed other strategies such as individual counseling, one-on-one counseling, this idea of a treatment buddy, and then also the data-informed educational counseling. Individual counseling was endorsed, saying, but if you have someone calling you and asking after your health, and you generally, that would be very helpful, not having to wait for your clinic date, which could be in August. A treatment friend to help me was described as, because if you have a problem, you're able to share it with your friend or else somebody that you live with. It could help me a lot because at least you can talk to them to say that you have a certain problem. And then finally, data-informed counseling, or let's see how you're taking your meds. This is encouraging because this one talks about you, but they're all encouraging. It is important to know how you've done so that if there is any mistake, then you can rectify the mistake because you understand how you've taken your medication. So taking and synthesizing these results in sort of a rapid turnaround fashion, we then went on to focus group discussions with each of the 3 groups of providers. And the first is the nurses and doctors. They tended to endorse very strongly, and although all 9 options were presented to them, they tended to endorse, for the most part, the combination type modalities, notably the individual counseling and the data-informed counseling combined with the check-in text, although there was some enthusiasm for the individual counseling alone as well. Maybe I like facts. The person hasn't come into the clinic for 2 weeks and is that kind of a person who takes their tablets every 2 to 3 days, and the way you approach that client will be different, and maybe the reasons or the barriers will be different from the one who missed 2 weeks versus the one who just takes them today and then doesn't take it tomorrow. And now you have data like that as a counselor, and then it means you're empowered to actually counsel specifically for the problem that applies to this particular patient. However, we also went on to have focus group conversations with both the community care workers and the counselors. And once again, these were separate focus groups, as these were distinct types of groups. The community care workers particularly endorsed, again, the individual counseling, as others had, the individual counseling together with the weekly check-in texts, and the support group approach, because we all have HIV, right? And then to get support from you, you tell me, no, man, you mustn't default. You must do this. You must do this because of this and this and this. And the other one will say, no, you mustn't default. You're going to be like this. You give me your advice. And I say, okay, it means I'm not going to die, and I continue with my life. The individual counseling and the data-informed counseling and the support groups were particularly endorsed by the counselors. And a typical quote was, they don't like to talk about their problems in front of other people. So that's why I choose the individual, the one-on-one between you and your counselor. And there you can say anything. So these were some of the themes that we identified in the conversations we had with individuals. And so to put this all together in a conclusion, I would say, and we've determined that peer support from the group and individual counseling were certainly consistently supported strategies favored by all. The focus group discussion groups, which were the providers of the different types, favored the counseling, whether individual or data-informed, or in combination with the check-in texts. The focus groups did not particularly, and this came through quite clearly, endorse just simply using check-in text alone. In other words, a tech-only solution was not strongly supported. Peer support groups and individual counseling, either alone or in combination with technological-oriented support, that is to say check-in texts, really seem to warrant attention for better scale-up in resource-constrained settings. And so putting this behavioral approach and supportive approach together with text or data support seems to have some enthusiasm in this group, and should be, in our view, further explored. And that is it. Thank you very much.
Thank you very much, Dr. Gifford. I always love it when we have both patient and provider perspectives in the study. So moving right along, our next speaker is Dr. Karen Ingersoll, who is a clinical health psychologist and professor of psychiatry and neurobehavioral sciences at the University of Virginia School of Medicine. She has several awards. I'm not going to list them all. We don't have time, but the most recent from this year, in January 2020, she and her research partner were named the UVA Innovators of the Year at UVA for their work on the Positive Links mobile platform to support patients in HIV care. And they subsequently won the 2020 Caceres Award from the American Academy of HIV Medicine and Institute for Technology for Healthcare and HIV Practice for their Positive Links mobile platform. As a clinical researcher, Dr. Ingersoll develops and tests interventions to improve the health of people living with HIV, reduce the risk of harms from alcohol, and encourage lifestyle change to promote health across the lifespan. Over to you, Dr. Ingersoll.
Well, good afternoon. I'm pleased to present recent findings from a pilot study of a novel eHealth intervention. This one is a different one than the one we won awards for. This is in a more early stage. And this one is designed to address the issue of substance use among people living with HIV. And it won't be a surprise to any of you that people living with HIV don't just have substance use as an issue, but in fact, there are other common problems that undermine ART adherence and therefore diminish HIV clinical outcomes. Some of these other factors include HIV and substance use stigma, poor social support, depression, concerns about HIV disclosure. Those are among the 6 most common problems that in the US undermine ART adherence. So in this project, we developed and tested a novel eHealth intervention. One reason we were interested in eHealth is that like in the previous presentation, patients were asking us for something they could do from home. And this was before COVID, but it's an interesting way to reach more people at convenience for them. So let me tell you about the intervention. Our intervention involved recruiting real peers living with HIV from a small local clinic who had a history of substance use and the other problems. Peers named it Peers Offering Support for Health, or PAWS for Health for short. And we used a process of video participatory research to create compelling content where the peers discussed talking about their own challenges about the 6 common problems, especially substance use, and how they overcame them. So they were all peers who were doing well at the time. Baseline and follow-up assessments for this intervention are conducted online. And the intervention, as you can see here, is presented in 6 weekly cores. In between cores, there are weekly diaries of ART adherence and substance use, along with automated emails to prompt logins. Now, the cores present some static content, but mostly offer interactive games and activities, along with short peer videos to help people think through challenges in living well with HIV, encourage practice of skills, and provide tailored feedback. The weekly metering of content was designed to provide time for skills practice, similar to what happens in weekly counseling. This is a sample of an interactive feature. There are a host of interactive games and features in the PAWS for Health intervention. This is a game in which a user can learn about standard drinks by sorting many types of drinks into a standard drink equivalent. And this helps people understand how much they're actually drinking. There's narration and music, there's immediate feedback of right and wrong answers, and there's a summation of what was learned with encouragement about using new knowledge going forward. In each core, there are short peer videos with diverse peers discussing their own journey with the problem. And in the real intervention, peers' faces are shown. This is an example of a peer tips video screen. When a user has reviewed a video, a green check mark appears, and users can view one or all of the videos offered on each topic. Peers give evidence-based and experience-based tips in their own diverse ways. Now, we tested PAWS for Health in a small pilot RCT and included adults living with HIV who could read English, access the internet, and reported non-adherence and substance use in the past month. The design was a 2x2 RCT with baseline and 3-month post-assessments, and participants were randomized either to the PAWS for Health intervention or an online control patient education condition. We tested the feasibility and acceptability of this new intervention and its impact on potential mechanisms of change, as well as exploring its impact on substance use and HIV clinical outcomes. Now, we had 331 applicants for the study, most of whom did not meet inclusion criteria. They were doing too well, with few declining participation. So we enrolled 51, and 7 failed to complete the baseline. So 44 were randomized equally among the PAWS for Health and the control conditions. And our study retention was high, with very few dropouts. So study participants were mostly men with high school education, with many disabled, retired, or unemployed, and most were single. Surprising to our team, they were mostly open about living with HIV, and many reported significant depression, recent non-adherence to ART, and varying levels of addiction severity. Let's turn now to data on the feasibility of the pilot study. So we compared the rate of baseline assessment completion among those who were eligible, and our benchmark for study acceptance was 56% based on the literature, and we found nearly 69% in terms of study acceptance. For study completion, we compared the rate to a benchmark of 80% in the literature and found nearly 89% in our study. So our study exceeded our a priori criteria for study feasibility. And next, we looked at program acceptability. And here we assess program features, utility, and actual usage, again with a priori benchmarks. We found that most users rated every program feature as a 3 or 4 on a 4-point scale. exceeding the benchmark for factors such as the ease of use, the convenience of the program, its attractiveness, and its fit for them. Users also rated each program feature on its utility or usefulness to their real life, and rated 64% of program utility features as mostly to very helpful. They gave poor ratings to the utility of 8 items, and this indicates areas for improvement in a new version of the intervention. Finally, we hypothesized that users would complete 75% of cores, but this benchmark wasn't met due to 6 users never opening a single core. So they completed the assessments but didn't look at the intervention. So overall, the program met 2/3 of our a priori benchmarks for acceptability. Next, I'm turning to AIM 2, which was testing the intervention's impact on potential mechanisms of change, such as knowledge, self-efficacy, and motivation, which could lead to behavior change. So here you see absolutely no impact on knowledge and no difference between groups. There was improvement in self-efficacy for ART adherence only in the Pause for Health participants, shown in blue, and self-efficacy about reducing substance use improved in both groups. Parallel improvement, which is a theme here. There's also parallel improvement in terms of 2 metrics of motivation, a VAS scale of importance, confidence, and readiness to change. ART adherence and substance use is absolutely parallel, no differences between groups. Same thing for the construct of patient activation. So only self-efficacy seems to be a plausible mechanism of change for further study of this intervention. Now, when we look at exploratory clinical outcomes, there were very small improvements in days in the past month of ART adherence in both groups, but parallel. And days in the past month with no drug use improved slightly with no differences by group. When we turn to alcohol results, it's a little more interesting. While both groups showed reduced drinking days in the past month, Pause for Health participants reduced their drinking days nearly by half. And those participants were drinking 1.5 more drinks per drinking day at baseline and showed a greater decrease at follow-up. While Pause for Health participants had nearly double the binge drinking days per month at baseline, this declined by more than half at follow-up, with no significant change observed among the controls. Therefore, Pause for Health participants are showing a larger impact on harmful drinking than the controls. Now, talking about general study feasibility, we found it very easy, surprising to us and actually to our grant reviewers, that we were able to recruit and consent peer role models willing to go on video talking about their lived experience overcoming these challenges while living with HIV. Also, participants in the study showed high rates of the 6 common problems undermining ART adherence, showing that it is feasible to recruit the right participants who could benefit from the intervention. Now, we had more challenges recruiting local participants, mostly because our local clinic was doing very well in terms of good ART adherence and not much substance use. So we had to pivot to a national recruitment strategy. That meant we had more difficulty obtaining labs and medical chart data to assess viral load, and therefore we failed to be able to assess viral load as a potential clinical outcome of the intervention. In terms of findings, we found that the study was feasible and showed acceptability, but the program was less used than we hoped. We got feedback from some participants that they really wanted a mobile version of this intervention, and we were not optimized for mobile display. Some participants still used it on their mobile phone, but it was pretty small and hard to see. And so this may be an area for improvement. In a preliminary look at hypothesized mechanisms of change, only self-efficacy seemed to be potentially useful. And so far, we found that the primary differential impact of Pause for Health appears to be a reduction of harmful drinking, which could be important given that alcohol is the most common substance used by people living with HIV. So our future directions are we may consider rebuilding and repurposing the intervention for harmful drinking only rather than drug use, drop some features that showed low utility, and update the program with responsive design, which would enable use on a mobile phone or other devices. We also want to use automated mobile assessments, brief ones that can capture behavior in real time. And finally, if we were going to look at viral load and viral suppression, I do not recommend to any of you begging and pleading distant pharmacies and providers to give you their medical chart data, because you're not going to get it. So instead, we're thinking about maybe dried blood spot testing to assess viral load in a future version of the study. Now, if IAPAC posts our presentations, you'll see this tiny version of references. But mostly I want to acknowledge the peers living with HIV who participated in creating a really amazing set of videos that really are the underpinning of the whole intervention. And thank NIDA for funding this project, as well as our additional partners. Thank you.
Thank you, Dr. Ingersoll, for a very interesting presentation. Moving right along. So we're trying to keep on time here. Our next speaker is Dr. Justin Knox, who is an epidemiologist whose research is focused on HIV, substance use, social networks, and racial and sexual minorities. Dr. Knox earned his PhD in epidemiology from Columbia University. His dissertation focused on substance use and HIV risk among social networks of Black South African men who have sex with men, which was work funded by an F-31 from NIDA and the U.S. Fulbright Student Program. He also has an MPH from Columbia University and a Master's in Science in Medical Anthropology from University College London. And he also served as a Peace Corps volunteer in Swaziland. Welcome, and over to you, Justin.
Thanks a lot, Bob, for the introduction. Let me just pull up my slides. Great. So hi, my name is Justin Knox. I'm an assistant professor at Columbia University now. And I had the opportunity to work with Prism Health at Emory University for the past year or so, and I will be presenting our research on explaining racial disparities and viral suppression among men who have sex with men living with HIV. So I'll start with some background. Racial disparities at each step of the HIV treatment cascade have consistently been shown in the literature, culminating in 30% lower likelihood of viral suppression in Black HIV-positive individuals. Further research is needed to identify modifiable factors that could account for these racial disparities in viral suppression, an important indicator for HIV prevention and treatment. So this is a brief outline of what I'll present. First, I'll describe the methods used in Emory University's engagement study, which provided the data used for this project. Second, I'll describe the participants of the engagement study, stratified by race, including the prevalence of not being virally suppressed. Third, I'll identify explanatory factors associated with lack of viral suppression. And fourth, I'll assess whether those explanatory factors account for racial differences and lack of viral suppression. So the analyses for this project used data from the baseline assessment of a cohort of a Black and white MSM called Engagement. Nearly all published data on people living with HIV comes from clinical cohorts, which are inherently biased towards participants being engaged in care. Community-based prospective studies are critical to understanding disparities and informing interventions because they include men who might not be engaged in clinical care. So the engagement study is one of the first community-based cohorts of Black and white MSM living with HIV in the South. Target enrollment for engagement was 400 sexually active Black and white MSM in Atlanta, all living with HIV. And participants were enrolled for a year starting in summer 2016. And men were recruited from community events, community-based organizations, and testing sites, and through social media. So these are the measures used in these analyses. Our primary outcome, plasma viral load, was collected for every participant at baseline, and that was used to assess lack of viral suppression, which we defined as plasma viral load greater than or equal to 40 copies per milliliter. And our primary question was how common lack of viral suppression was in Black compared to white MSM. And then we sought to understand what explanatory factors might be driving any observed differences in viral suppression among Black and white MSM. And these included sociodemographic characteristics, psychosocial factors, as well as biomarker data for STIs and substance use. For the statistical analyses, we use predicted margins methods to estimate prevalence ratios using logistic regression. Initially, a bivariate model was run to estimate the association between race and viral suppression. Our goal was to understand what is driving any observed racial differences in viral suppression. So in order to accomplish this, we added potential explanatory factors into that bivariate model one at a time. And if any factor decreased the prevalence ratio for race by 5% or more, we considered that to be meaningful. Finally, we wanted to know whether the combination of any meaningful explanatory factors accounted for all of the observed racial disparity. For this, we added all meaningful explanatory factors into a multivariable model. And these are the results. There were 398 participants with baseline viral suppression data. You can see there was an even distribution of participants by race. And these are some of the sample sociodemographic characteristics. I'll just highlight some of the major differences between Black and white participants. There was distribution across age ranges with more Black participants in the younger age ranges. Also, half of Black participants were in the lower income bracket compared to a third of white participants. Now on to psychosocial factors. Housing instability, including homelessness, was nearly twice as common among Black compared to white participants. Incarceration in the past year was more than twice as common among Black compared to white participants. And generally, there was a lot of coverage for HIV treatment. Data on the sources of ART coverage are not shown and they can be overlapping, but 3 in 4 reported having ART coverage from private insurance, 1 in 3 from government programs, and 1 in 4 from pharmaceutical company drug programs. Nonetheless, too many people still did not have coverage, and this was nearly 3 times as common among Black compared to white participants. And here's some of the data on drug use, which was based on self-report use over the past 6 months or positive lab results. There was a high level of marijuana use in both groups, but especially among Black participants. And methamphetamine use was also high and was nearly twice as common among white participants compared to Black participants. And finally, our outcome, lack of viral suppression. Overall, a quarter of the sample was not virally suppressed at baseline, and we observed a considerable racial disparity. 1 in 3 Black participants were not virally suppressed at baseline, compared to 1 in 5 participants. And that difference translated to a crude prevalence ratio of 1.6. So specifically, Black participants were 60% more likely to not be virally suppressed at baseline. Next, we wanted to see if this racial disparity could be accounted for by the explanatory factors that we measured. So this slide shows the explanatory factors that were significantly associated with lack of viral suppression in the whole sample and the strength of that association. They are all in the hypothesized direction. For example, men in the younger age ranges were more likely to not be virally suppressed. Another example, men in the lower income bracket were more likely to not be virally suppressed. And the variables in bold are explanatory factors that were significantly more common among Black participants. So finally, we wanted to see if those explanatory factors could explain the racial disparity and lack of viral suppression. Because Black participants were younger on average than white participants, and age is not a modifiable factor, we age-adjusted all analyses. So the age-adjusted prevalence ratio for lack of viral suppression among Black versus white MSM was 1.4, which is shown at the top. The black circle represents the age-adjusted effect estimate for being Black on lack of viral suppression, and the bars extending out of the circle represent the 95% confidence intervals. As you can see, the confidence interval does not cross the null, which is represented by the dotted line, and so the difference is statistically significant. Then each subsequent circle represents the age-adjusted prevalence ratio for race and viral suppression, with that additional explanatory factor adjusted for in the model. If the circle is in the green area, it indicates that variable meaningfully attenuated the racial disparity, which you may remember we defined as a reduction in the prevalence ratio by 5% or more. We made those circles larger to stand out. They were income, housing stability, having had at least 1 viral load test in the past year, having ART coverage, and marijuana use. And finally, at the bottom of the figure are the results from the multivariable analyses, which included those 5 meaningful explanatory factors in a single model. So for this slide, we pulled out the main findings to highlight them and make it more clear. The following 5 explanatory factors attenuated the age-adjusted association between race and viral suppression by 5% or more. The percentages are proportional decreases in the prevalence ratio, and they're listed in descending order, and they're all modifiable. ART coverage, having had at least 1 viral load test in the past year, which we interpret as a proxy for being in care. Housing stability, which included homelessness, income, and marijuana use. And this slide shows the multivariable results. In the multivariable model, with the 5 covariates that were found to meaningfully attenuate the age-adjusted racial disparity, the association between race and viral suppression was 1.1, which is close to null. That association is no longer statistically significant. So combined, those 5 variables accounted for a 23% reduction in the age-adjusted prevalence ratio between race and viral suppression. So I will end by summarizing the findings and discussing some of the implications. First, Black MSM were more likely than white MSM to not be virally suppressed. Second, Black MSM differed on many potential explanatory factors for differences in viral suppression. Third, 5 factors were observed to meaningfully account for the disparity between Black and white MSM. They were having ART coverage, having a viral load test in the past year, housing stability, income, and marijuana use. Combined, these 5 explanatory factors completely accounted for the racial disparity. So if we're serious about reducing racial disparities in HIV treatment outcomes, these results show that there are clear opportunities to target modifiable factors that would have an impact. For example, 14% of Black participants did not have coverage for their ART prescriptions, even through governmental programs or pharmaceutical company drug programs. And this factor accounted for a 12% reduction in the racial disparity in viral suppression. Georgia and other states that have declined Medicaid expansion or implemented waivers that would support the care for people living with HIV, that would make a difference. Also, as an example, 30% of Black participants reported housing instability, and this factor accounted for a 7% reduction in the racial disparity in viral suppression. Housing support for racial and sexual minorities living with HIV needs to be improved to reach its intended target. Our findings also provide direction for further research. For example, these analyses were cross-sectional and need to be explored further using longitudinal data. Also, we focused on individual characteristics, and there's a need to further explore social environmental drivers of racial disparities in HIV treatment outcomes. In summary, we feel that there are important policy and intervention implications from these findings. I'd like to thank my co-authors, engagement study participants, support research staff, and our funders. And thank you all for your attention.
Thank you, Dr. Knox, for another interesting and rich presentation of really important research. Okay, on to our last but not least, but the final abstract for this session. We have Dr. Alexander Lankowski, who is a Fogarty Global Health Fellow at the University of Washington and a Research Associate in the Vaccine and Infectious Disease Division at the Fred Hutchinson Cancer Research Center in Seattle, Washington. He's a board-certified infectious diseases physician with experience providing HIV primary care and prevention services in a variety of clinical settings. His research focuses on understanding and addressing barriers to HIV care and prevention experienced by vulnerable populations in the US and globally. He is currently based in Lima, Peru, where his work focuses on developing strategies to support HIV testing and linkage to services among key populations. Thank you for being here. Over to you, Dr. Lankowski.
Sorry, just trying to unmute myself. Thank you very much, and good afternoon, good morning to everybody. Thanks a lot for this opportunity to present, and it's a real honor to be included with these other speakers. Really enjoyed the talks that preceded me as well. So I'm going to talk about a recent study that we did looking at longitudinal PrEP outcomes at the Kind Clinic, which is a freestanding sexual health center based in Austin, Texas. This work was the result of a collaboration between that involved myself and Julie Dombrowski from the University of Washington with our colleagues and co-authors at Texas Health Action, which is the parent organization of Kind Clinic, Dennis Chow and Samuel Goings. So I don't have any disclosures to report. To begin with a little bit of background, as is illustrated in this map here, there's a well-recognized disconnect between PrEP need and PrEP access in our country. And some of the starkest disparities, which are depicted here in red and orange, are concentrated throughout much of the southern and southeast states. So improving PrEP coverage in this region in the US South has been articulated as a key goal of the National HIV Strategy. But to date, there's really few published reports describing PrEP delivery in real-world clinical settings in this region. So the Kind Clinic is a comprehensive sexual health center. It was founded in 2015 in Austin, and really in response to an unmet need there for PrEP, as well as for quality sexual health services more generally in the LGBTQ+ community. After starting out as a grassroots, completely volunteer-led initiative over the last 5 years or so, Kind Clinic has really grown substantially. They have opened up satellite clinics in San Antonio in 2018, more recently expanded to include 2 additional clinics in the greater Austin area, all of which offer the same full range of sexual health services. So the analysis that I'll present here today has 2 main objectives. The first of which is to describe retention and care over the first 6 months after PrEP initiation among new PrEP users at Kind Clinic. And we also sought to explore the relationship between baseline factors and retention and care over time. So before I go into the details of our analysis, I wanted to just tell you a little bit briefly about the service delivery model at Kind Clinic, which I think really exemplifies the ideal of HIV status neutral care, encompassing the full range of testing, treatment, and prevention services, all framed within the broader context of sexual health and well-being. Care at Kind Clinic is organized into 4 main service areas: HIV prevention, which encompasses PrEP and PEP, HIV testing and treatment, STI testing and treatment, and a dedicated gender-affirming care service that focuses on specific needs of transgender and gender non-binary patients. Additionally, Kind Clinic launched a telemedicine service called Telekind in mid-2018. And as you might imagine, this is something that's been hugely important recently and very valuable. Patients who access clinical services at Kind Clinic also pay essentially nothing out of pocket for their care, including to receive PrEP. This also includes an internal assistance program to help support the cost of the drug itself when it's not otherwise completely covered by other mechanisms, such as a manufacturer drug assistance program or private insurance. And as such, it's only very rarely that any patient at Kind Clinic has any out-of-pocket costs associated with accessing PrEP. So we conducted a retrospective analysis of retention and care among new PrEP patients at Kind Clinic. We used the electronic medical records to extract baseline sociodemographics and clinical factors, as well as longitudinal data related to follow-up visits and HIV testing. We included in the analysis all adults aged 18 years or greater who completed a PrEP initiation visit at Kind Clinic during the 12-month period from November 2017 through the end of October 2018, excluding those who tested positive for HIV on or before their initial PrEP visit date. The study period that we selected represents the first 12-month time span after Kind Clinic implemented an EMR system, which established a reliable electronic record keeping that enabled us to be able to perform the analysis. In addition, longitudinal data for the study was captured far enough out to ensure that the full cohort would have at least 6 months of observation time to be able to assess outcomes. So our primary outcome of interest was retention and care. which we assessed at both 3 and 6 months. We classified patients as retained in care at 3 months if they attended at least one PrEP follow-up visit within 3 months of their start date. And we defined 6-month retention as having attended at least 2 PrEP follow-up visits within 6 months. All components of the initial evaluation at Kind Clinic, including baseline labs and the initial prescription, occur in the context of just a single encounter. And follow-up interval or follow-up visits occur at intervals that are consistent and dictated by the existing CDC guidelines, which is highlighted in the figure on this slide. So patients return for an initial 1-month check-in visit, then again at 3 months, and then at 3-month intervals thereafter. So as you can see, at the 3-month mark, patients ought to have at least 1, if not 2, follow-up visits. And then at the 6-month mark, patients who remain engaged in care ought to have at least 2, if not 3, follow-up visits. And we felt that these definitions were hopefully stringent enough to capture the retention outcome in a meaningful way, while at the same time being sufficiently flexible to be appropriate as a metric for a real-world clinical setting context. So onto our results. So nearly close to 1,200 individuals started PrEP at Kind Clinic over the 12-month study period. Median age was 30 years, 73% identified as white, 37% identified as Hispanic or Latinx. And in terms of gender and sexual identity, the vast majority, so over 90%, were cisgender men who have sex with men. And 4% identified as either transgender or gender non-binary. Roughly 2/3 had a post-secondary degree, and 78% received at least some form of financial assistance. And some of the other factors are listed there on the table on the right. So the main results with respect to retention, overall, based on our definitions, we found that 75% of Kind Clinic patients who started PrEP during the study period were retained in care at 3 months and 63% at 6 months. On the left, you can see plotted with a little bit more granularity the time to the first follow-up visit. And notably, just to point out, even though this isn't something that was captured by our outcome definitions, a very high proportion, 88% to be exact, ended up having at least 1 follow-up visit by 6 months. And there was just a single HIV seroconversion noted during the study period. So we also conducted bivariate analysis to assess for baseline factors that were associated with retention and care at each of our 2 time points. Briefly, to summarize the relationships that reach statistical significance here. So we found that cis MSM, as compared to those with any other gender or sexual identity, were significantly more likely to be retained at both time points, while having an HIV positive partner was actually associated with lower retention at both time points. At the 6-month time point only, age and educational status were both associated with increased retention, while patients who received PrEP payment assistance were slightly less likely to be retained at the 6-month time point. So just to briefly put our findings from Kind Clinic in context, this table is a summary of previously reported PrEP retention estimates from other real-world US clinical settings. And as you can see, at comparable 3 and 6 month time points to ours, PrEP retention is generally in the range of 70 to 75% and 40 to 60% or so, respectively. And these numbers track relatively closely with the 74% and 63% that we found to be retained in care at Kind Clinic. And our, which if anything, ours are, what we found at Kind Clinic was slightly above what had been found in prior studies. So in conclusion, we found that PrEP retention in care at Kind Clinic was similar to, or perhaps even exceeded, what had been reported in literature from similar routine clinical care settings in the US. And based on these findings, Kind Clinic and its very inclusive, sex-positive, HIV status neutral approach to care delivery may offer a valuable model for future PrEP delivery programs in the US South and elsewhere. In terms of future directions, Kind Clinic continues to grow and actually seems to be doing remarkably well in weathering the challenges of the COVID-19 pandemic, having expanded one clinic in San Antonio and actually opened up an entirely new location just a couple weeks ago in Austin. And they have potential plans to further expand their telemedicine service to be able to reach patients across the entire state of Texas. And then finally, as in many settings across the US, I think a lot of work still remains to be done to address ongoing racial disparities in PrEP coverage and outcomes. And this is something that that I know resonates very deeply with Kind Clinic's core mission and values, and to which they're highly committed going forward. So thanks very much. Just wanted to thank specifically everybody at Kind Clinic and Texas Health Action, including my co-authors, Dennis Chow and Samuel Goings, also Julie Dombrowski at University of Washington. Thanks to the conference organizers. And for any specific questions about Kind Clinic, I would direct you to my colleague, Dennis Chow at Texas Health Action and Kind Clinic, who can probably answer specific questions about the care model and operations there better than I can. And feel free to reach out to me as well. And I'm happy to answer questions specifically also about the analysis. Thank you very much.
Thank you, Alex. That was really rich again and really interesting. I want to thank all of these speakers, and I also want to congratulate each of you for being in the top 4 late-breaking oral abstracts. I think we can see why. They're all very rich studies. And I want to thank you all for being so clear and succinct in pulling together so much data and presenting the results to the audience. So thank you very much. We are going to close this session right now, and everybody just hang on. There'll be a very, very brief pause, and then we'll be back for closing remarks to the conference. Thank you all.